Good afternoon, everybody. It is a real honor for me to be here this afternoon, and I'm a little intimidated to follow everybody, but I'll give it a shot. So I was asked to present about Bridges to Healthy Transitions, which is a research initiative housed in a regional medical campus in eastern West Virginia. It's really much more than a research initiative, however. So it builds on a lot of the work that I did with HIV and AIDS in the state of West Virginia beginning in 1982, which is when I took care of my first HIV patient. And back then, for the first 10 years, we had very little other than prevention and palliative care. So what we needed to really do was to build community, where people were terrified. There were people who were murdered because they were HIV positive in West Virginia, so the danger was very real. So I was one of the people, but there were many other people in the state of West Virginia that galvanized communities across the state to be caring communities, compassionate communities for people living with HIV. And then we started working on the healthcare professionals and building capacity on that side. So in that, we build capacity at the community level, we build capacity at the professional level, and then we started building the bridges. And that is that's really grounding in terms of what I do and my approach to this research initiative that we have at West Virginia University. So I am a community nurse, unabashedly. It's who I am. It's in my lifeblood. You couldn't get me back into a hospital if you tried. So I admit it, I'm a recovering community advocate. Okay, so in terms of what the lessons I take from what we did with HIV and what we were able to do, looking back at it, is the things that we did that were the most important is that we really listened to and we heard the concerns of people out in the community. We listened and heard the concerns of the professionals who are taking care of people in hospitals and in primary care settings. We heard what they were saying. We addressed those issues and we creatively problem solved so that they could do so that we could ameliorate the issues. And we did the same thing for people living with HIV and their families and all those circumstances around that. And I think that that is critically important, is really listening and hearing what everybody is saying and then coming to some solutions so that we can be working together. And I think that is very relevant to palliative care when we're thinking about where we are and where we need to be going in terms of serious illness. And then the second thing that I think that we did particularly well, and when I feel the most grounded and the most successful, when it's not about me, when it's really about the folks that we're working with and trying to make the situation better for them and helping them, in terms of realize their preferences and wishes. And again, I think that's something else that when we think about the noise, and what was the expression this morning, meaning taking, and all that noise that we hear in the healthcare settings that we're in. I'm in academia, God help me. It's the same thing. There's lots of noise out there, and it's easy for us to lose track of what's really the most important, why we're here and why we're doing what we're doing. So I think those are two lessons that I think are kind of my touchstones that I take forward with the work that we're doing today. Now, the status of health in West Virginia is not good. We are 50th in the United States for diabetes, heart disease, hypertension, all the things, preventable death, preventable hospitalizations. I often look for somebody is there anybody from Mississippi in the room? Because, we typically go flipping back and forth between those things. Now, this is great for me with grant proposals. It's never difficult to substantiate a need. But what it is what we're seeing is really young. These are not people who are, I did a focus group with a community health center where the geriatrician said, I can handle having these conversations with people who are 80, who are in their 70s. I'm having these conversations with people who are 35 and 40 and they've got kids. I can't do this because they are so sick. And so this is what we have. This is our reality in West Virginia. So serious illness in West Virginia, because of the poverty and the lack of access to health care, these are illnesses that should be chronic and people should be living with for a very long time. They're not. They're serious. And it's a real issue. The problem is the way that on top of this, the symptom and the caregiver burden is exceedingly high. But more importantly, what I'm seeing in terms of the intergenerational impacts, and these are the children I mean, one of my studies, a 6-year-old was taking care of her grandmother who had COPD. She was 54 years old. She was end stage, had signed out of hospice, and she was the one, she's supposed to call 911 if something happened to grandma, 6 years old. So there are children that are taking care of their grandparents and their parents who have these very serious illnesses. And when we think about that, 22% of high school dropouts in 2005 were associated with family caregiving responsibility. Translate that to a state where kin take care of kin, that this is an expectation, and think about that long-term impact of what happens. So it is so important that you do what you do and that you do it well. But when we're thinking about it, think about the family and the next generation. And lastly, most of our programs are really kind of set up in West Virginia for people who are aging. And they talk about, we have such a graying state, and we do have one of the oldest states, in the nation. The issue is that the next generation is not going to get there. It's not going to be a problem. They're going to die, and they do die. And I'm concerned about what's going to happen with the next administration because they're dying now. So what do we do with Bridges to Healthy Transition really started when I came back from a postdoc. I've lived in West Virginia the entire time. I commuted for all my education. And so I took a position with a regional medical campus, and my research training actually is not for this at all, but I had to do something that was going to make sense for the community and where I was, because it's where I wanted to be. It's my home. So we take a community orientation and an ecological approach. So we take a look at how policy affects the day-to-day. So it's a comprehensive approach to research. We use palliative care as a framework. We use the domains as just kind of a framework, as a quality framework. In my mindset, it's just the way we're supposed to be doing things, right? It's a specialized body of knowledge, and especially when we think about nursing. Maybe it's not, with medicine, it's more novel, but with nursing, this is what we're really supposed to be doing, and social work. And so that's how I kind of use this, kind of as this template or a framework to look at, this is the gold, this is the benchmark, this is what we want to get to, how well aligned are we to this? And again, I also think about it very much in terms of primary and secondary prevention. It's not about getting the advanced directives and easing, into having a good, high quality death. What it really is about is taking care of the next generation. That's what it's really all about. And what are the things that we can do by moving palliative care farther upstream, or translating palliative care science into standard practices or primary palliative care? What can we do to do that so that we can be looking at these long-term, so that we really are primary and secondary prevention? So finally, we have loads of partners. I am so blessed in the state and then where I live in the state, because I live in the Eastern Panhandle, which is near DC and Baltimore, to have a lot of people who are very engaged in the community and very committed. We have the Health and Human Services Collaborative that brings together health and human service professionals for 3 counties in the Eastern Panhandle. It's been heavy on social work, but I've been kind of switching that a little bit, that these are health issues. I mean, you can't really divide them now, can you? The United Way and the Family Resource Network, so these are really good partners that we work together with. With the Bridges to Healthy Transitions, I originally had an advisory board, but it just started that it didn't make a whole lot of sense to have another separate advisory board for more meetings that people had to go to. So what I've done is more integrated into the other groups, so that I'm a part of it. We work together, and there's maybe special projects that will pull people out to do specifically, but that's how I'm actually embedded in these different steering committees. And that way we know that we're generating the data, we're asking the right questions, so to getting the right answers to the right people so they can do the right thing. And this is the way that, even though it may not be a big study that we publish someplace, it's getting to the right people so that we can kind of change what they're doing and how they do it. We also work with the voluntary networks and persons caring with and living with serious illness. The voluntary work networks that we've really kind of tapped into have been Meals on Wheels. We kept on talking with this aging population. They're invisible. If they're not real sick, if they're the frail elder and they live in a rural area, I mean, then nobody's going into the home. We just don't know, so they show up as train wrecks. So what we started doing is thinking, how could we do this? Well, Meals on Wheels goes into these homes anyways. Why not just give them a little bit of training, right? There's reasons why you go into the home, and one of those reasons why is you do home assessments, right, to see if there's any safety issues and what's going on. So that's the kind of thing that we do and the way that we approach it. And in thinking about it, there's no reason why we couldn't do a little palliative care training too and having the chat, because people feel, the people who have the closest proximity to people, they feel the most comfortable talking about with these things. And then finally, we've been doing some statewide work with the Partnership for Elder Living, Future of Nursing campaign, where we have this community nurse project that we're going, I'm calling it Resuscitating the Community Nurse. It's those community nurses who are out there just doing and addressing and meeting the needs that they have in their community. And I'm very excited about that. And then also we're bridging with our Children, Our Future campaign. So what do we do? I've already talked some about it, but we do comprehensive assessment. I do the community health needs assessments for both of the hospitals, which is awesome because then I get to write the survey and I get to ask the questions I want to ask and I get to choose the approach. And so what we do then is go out and do a lot of focus groups, key informant interviews. And again, this is a way of getting the information in front of the board of directors so that they can be thinking about their strategic planning. And I'll address that in just a minute, some things that we've been able to do. And again, along with those lines with my HIV work, what we look at is informal care networks and how that operates out there in the community. Who are people turning to? Who do people talk to? Then we look at the formal side and how the formal side really operates. And then we look at the interface, which is typically like this or like this. From what we've seen. I'm particularly fascinated with culture because I think it really kind of shapes everything that people do on a day-to-day basis, especially when we're talking about serious illness and these very serious issues that, that we need to be discussing. Culture really shapes it. When we think about the medical subculture, that you all probably run into quite a bit, we have the same thing with nursing. We have the same thing with social work. Are these subcultures that are very important to understand and address in respectful ways. And then finally, this impact of policy. I mean, when I take a look at all the studies that we've actually done and the ways that policy really and regulations impact access to care, we look for reimbursement, but there's always going to be this gap between, and people keep falling through the cracks in between those regulatory barriers. And so that we try to do is then document when you make this decision, this is what happens on the ground, and then we try to collect some cost data associated with that. So what we do with all this information, then we translate that back into research studies and then the education we do with nurses and medical students and social work students. In terms of palliative care science, we have, again, this goes back to the notion of taking a look at how can we translate palliative care science into tailored interventions at multiple levels. And I'll give you some examples of that in just a second. Health planning, program development, and practice redesign. Am I over? Oh no, okay, I'll go really quick. So these are just a couple of the studies that I've been involved with. The first one was building capacity. It was a R15 from NINR. And some of the major themes that came out was that give me something so I can help myself. And this is something that comes out from patients, participants in the study a lot, where they're saying, I go to the doctor, an example, I go to the doctor, I'm having a really hard time breathing, I tell him about it, I'm really anxious, then it makes my breathing worse, he gives me medication, and he tells me not to take it. She goes, what's up with that? I say, I don't know. But then we talk, has she ever talked to you about maybe relaxation, about positioning, using fans, all of these things? Have any of the nurses talked to you about that? No. That's what I need. Give me something so I can help myself. And I think that's what often happens, is that we don't give people tools so that they can help themselves and really respect what their preferences are for how they would like to self-manage and be respectful of their rugged independence. Do I have to die so my daughter can have a life is a notion in terms of looking at the impact or the burden of being cared for. But also, I think what it speaks to is this connection with family, and that's come through with a couple of other themes in presentations today as well, is that there's real who they care about is not us, they care about their family. They care about what's going to happen to their family. They care about what is happening to their family, and that's really important that we remember that, again, it's not about us, it's about them. And the third one that I just think is very important, they don't listen and they don't hear me. And it's that they don't hear me. They are talking about, some people may talk about functional decline. I used to means that they're talking about something they used to be able to do that they can't do now. It may be a signal that it's functional decline, disease progression. We're not picking up on it, and people are being hospitalized. So I think that's really, these are three important clues that we've integrated that into the interprofessional educational collaborative. This was done with home health agencies. skilled nursing facility, and then a primary care center, which happened to be a free clinic, where we did observation, and we identified how was the structure and processes of care. We found that they were really nursing Medicare rather than nursing the patient, even in ways that were contradictory to the goals of keeping them out of the hospital. So we developed we did an organizational assessment in terms of, again, using the domains of palliative care as questions to kind of assess where they were with it, the individual behaviors of the nurses, physical therapists, nursing assistants in terms of symptom management. And we developed an educational intervention. The two things that we needed to do was communication. Those were the things, and the second one was symptom assessment and management, that those were the two most important things. So we developed the education around that. And then we developed toolkits. So they would go in and do their OASIS form, and then they would go back the next day and go through this little assessment that was a person-centered assessment. So talk to me about what your understanding about your illness is. All those, what's important to you, really getting to know the person, and then co-developing a plan of where they're going to go, from here. And then finally, the West Virginia Elders in Transition and Chronic Advanced Illness, very quickly, what we identified these were surveys of both the formal side and informal caregiving, and we found that kids were taking care of family members throughout the state. One of the things that we thought about, though, is how could this be a win-win? We could say this is awful, or we could develop something so that we could give the kids the skill sets that they need. So we developed an educational program that was taken into the high schools. They graduate with a certified nursing assistant. They had the skill set. They had a job when they got up. And they said, the problem is that they leave and they go to nursing school. I said, awesome. That's great. And then finally, the community health needs assessment that we have done, we did cycle 1, and we've totally re-steered the hospitals that they're doing more with behavioral health, and we've been able to build more capacity in terms of behavioral health in the community. And finally, in terms of looking at, we did a lot of internal work in terms of managing diabetes in people with chronic illness within the hospital, and then there's also maximizing synergy among many different initiatives. So finally, this is one of my favorite quotes. We cannot solve our problems with the same thinking we used when we created them. And I think that this is an important time for us to be thinking about this again. Here we are again. I'm a historian, actually, by training. And we've been here many times before. So my question is what are we going to be doing differently this time? So we don't have another group in the next generation that says, oh, palliative care was great, but now we need to do this. So that's my question, and that I leave you with. And I thank you very much for your attention, and I'm sorry I went over.